Episode 4 of Solving Healthcare, aka the Quadcast.
Welcome to Solving Healthcare. I'm Cordial Caramantang. I'm an ICU and palliative care physician here in Ottawa and the founder of Resource Optimization Network. We are on a mission to transform healthcare in Canada. I'm going to talk with physicians, nurses, administrators, patients and their families because inefficiencies, overwork, and overcrowding affects us all. I believe it's time for a better healthcare system that's more cost-effective, dignified, and just for everyone involved.
This episode is brought to you by the Resource Optimization Network. This is a group of clinicians, administrators, researchers, allied health professionals looking to improve the healthcare system by any means possible. So if you're looking for a team to provide research advice, consultation, or how to do knowledge translation, please reach out to Resource Optimization Network at resourceoptnet@gmail.com or check out the website at resourceoptimizationnetwork.com. Okay, crew, we're at episode 4 of Solving Healthcare, and this one's a good one. But before getting to it, I gotta get a couple things off my chest. Number one, this is our 4th episode, and I've yet to thank our producers, Laura Thompson and Yasmin Chowdhury, who, without their help, I for sure wouldn't have been able to produce this bad boy. So thank you guys for all your help. Second, my wife heard the episode with Dr. Tamina Epen, and she heard us talking about how free psychotherapy would be amazing and how could we end up doing that in the Canadian healthcare system. And me being the silly husband I am, forgetting that my wife works at a family health team that provides free psychotherapy for all members within that family health team. So there is actually a structure within Ontario that allows for extended allied health services. So we're going to have a separate episode on that. Hopefully, Matt, if you're listening, you're gonna join the podcast. So yeah, I paid the price on that one. Okay, next, I got to tell you about our guest on episode 4. His name is Duane Hickling. He is a urologist over at the Ottawa Hospital. He is an expert in female pelvic reconstruction surgery. He's also a scientist at the Ottawa Hospital Research Institute. And the reason I have him on today's show is his innovative ways on how to improve the patient experience. He's invested in medical scribes, i.e., individuals that sit in his clinic that help transcribe the notes of that patient interaction. And he also participates in e-consults or virtual clinics in which assistance of mobile device, your phone, your tablet, or your laptop or desktop computer, you can have consultation or visit with Dr. Hickling. So I hope you enjoy this episode. I got to tell you, I love this. I know Duane for a long time, so you could hear the authenticity in our interaction. So I hope you enjoy it.
Duane Hickling, welcome to the podcast.
Thank you. I'm very excited to be here.
All right. So, Duane, we've known each other for how long would you say?
Probably 45 years.
Yeah, about 45 years. And happy 42nd birthday, by the way. Thanks for coming. I think we could start off by you describing what is the day in the life of a specialized urologist such as yourself.
Well, a lot of variability in my days. So a fair amount of time is spent in the clinic. So I see consultations, follow-ups, but I do have days where I do a lot of diagnostic testing, urodynamics, cystoscopy, and then, of course, OR days, typically 1 day a month. Mm-hmm. So day starts very early, 6 o'clock. Never really know when we're going to get done. Sort of when the work is done, that's when we go home. And it's pretty routine that way. I also build in some research time. So at least 2 days a week I spend focusing on projects and research questions.
Nice. And talk about your practice too. Like, you got some pretty sophisticated training in New York. So what patient population are we talking?
So my practice is fairly focused on female issues in urology. So the training I had was in female pelvic medicine and reconstructive surgery. I see women with a number of different urologic issues, and included in that is pelvic organ prolapse, urinary incontinence, voiding dysfunction. And also, as part of my practice, I see a lot of people with neurologic lower urinary tract dysfunction. So this happens to be in patients with spinal cord injury, multiple sclerosis, Parkinson's, and every other neurologic condition. There's a high prevalence of urologic conditions and complications. Mm-hmm. And that makes up a big part of my practice as well.
Okay, so in your world, say specific to the pelvic reconstruction and female urology world, where do you see the problems in the healthcare system?
I think in that specific field, I think we don't do a very good job addressing potential issues before they happen. Mm. So I'll give you an example. Pelvic organ prolapse and incontinence is very prevalent, but a potentially preventable condition. We don't do a good job recommending first-line therapies like pelvic floor physical therapy, postpartum physical therapy, to ensure health of the pelvic floor and avoiding some of these pelvic floor disorders. So there's injury that can happen with childbirth, with pregnancy, and we don't tackle that early on in the early stages, and we're kind of dealing with the problem later. And I think a lot of these conditions could be prevented if we had a better system in place and we had better coverage for interventions like physical therapy.
Yeah, because that's fair. Because right now, unless you have an excellent insurance plan, if you're a government employee, you're not always getting physio covered, correct?
It's true. There's many patients that I see who I think would benefit from pelvic floor physical therapy, whether that's for incontinence or pelvic floor dysfunction leading to voiding issues. They often can't afford physical therapy and they don't have insurance, and programs like Ontario Drug Benefits don't cover physical therapy. And sometimes that's really the only solution to their problem. And they just can't do it.
Maybe walk us through then, like an example of a patient that is not getting that physiotherapy. Like, what's the extreme end of that? What does that look like?
This would be very extreme, but I have seen patients who have very bad pelvic floor dysfunction to the point where they're unable to empty their bladder. They require catheterization or eventually some form of major reconstruction, urinary diversion, which could potentially have been avoided if they had a prolonged course of physical therapy that was covered.
So literally, if I'm understanding this right, you don't get your physio, you require some sophisticated surgery that divert essentially your urinary tract away from down below.
Right.
And in terms of like rehab, in terms of time in the OR, what is a patient looking like?
You're looking at potentially a all-day OR for some reconstructions with lifelong follow-up, potential for bowel issues, for infections, for long-term need for secondary procedures or reconstructions, hospital admissions, for this type of surgery, 7 to 10 to 14 days of recovery, and then the rehabilitation, and 6 to 8 weeks at least off of work, sometimes more.
So, I mean, what you're describing, a problem that could be better addressed by having something as simple as physiotherapy early on. Without it, we're seeing, potential for prolonged OR, prolonged dysfunction, poor quality of life. Would that be fair to say?
Absolutely.
And the reason I thought it was worth bringing this up is physiotherapy, something as simple as that, how effective and how important it can be. And this is once again a first line treatment that is not covered, which if you think about it, why not? You know, like if, you know, we fund all these other maybe medications that are not necessarily beneficial. And, you know, I just, it's a bit frustrating when you know that something as simple as physio can have such a huge impact.
Yep.
And when you see that the first line for cuts is usually physiotherapy or any kind of allied health professionals, it's kind of insane when you think about it.
And if you look at other healthcare systems, like in the UK, for example, if you're a woman with stress urinary incontinence and you're coming in to see your surgeon looking for an operation, you don't qualify for that operation unless you've had physical therapy. Wow. And it's covered in that system. Mm-hmm. So it's a totally different perspective. And we know that a vast majority of patients with that condition can be successfully treated, or at least their symptoms improve to the point where they don't need surgical procedures or other more aggressive types of interventions.
Yeah, that's going to be for sure a show that we'll do at some point. It's the power of the physiotherapist, because, you know, it is when you hear stories like that and you hear about systems that do have that in place and the effectiveness of that, like, that's brilliant. You're not getting an OR until you have been, until this resource has been exhausted. I think that's beautiful. I'm going to switch gears a little bit, because the main reason I wanted you on the show, you would think would be to talk fantasy football, even though I did demolish you a couple weekends ago. It was sinister. You do two things that are innovative as far as I'm concerned at the Ottawa Hospital. So one is the virtual clinics where you could see patients from afar.
Yep.
And the second thing is you use scribes. Okay.
Yes. Yeah.
And maybe talk to the listeners a little bit about your scribe experience.
Yeah. So this started about 4 years ago. I was finding that I was just drowning in paperwork, having a tough time keeping up with my charting, getting behind seeing patients. And I just found that to be very stressful. I felt that I could improve in terms of my delivery of care, but also just how I enjoyed my job. And sort of after actually talking to you often about kind of getting rid of the things that don't make you happy at work. And this was the one thing that I found really was holding me back and kind of bogging me down a bit. And it was actually a resident of mine who said, well, we were talking about this exact issue. And he said, well, have you ever heard of a medical scribe? And I said, yeah, a medical scribe, of course, you know, in Egyptian times, he'd follow you around and write on a papyrus or something like that, right? That was what I had in my head. And this person said, no, this is something that's really taking off in other countries, and they're using it a lot in the US. So it got me thinking, and I went online and I actually found there was a scribe service in Canada, and it just happened to be in Ottawa. So there was an emergency physician at Queensway Carleton. So sort of on a whim, sent him an email and said, hey, you know, would this apply to me? Are you up and running? Can I do this? And he got back to me right away. We met a few times, talked about how this was going to go. And then I started looking into the possibility of bringing the scribe into the Ottawa Hospital. Mm-hmm. That process took a long time. Had to get buy-in from multiple levels and had to go through appropriate channels through human resources and security and many other different features. Finally, when we got approval, we started doing it, and it was had an immediate impact.
Wow.
From day one. And I have to say, of all the things I've done in my practice to improve my time at work and what I think is my efficiency and workflow and patient care and patient satisfaction, that would hit on all of those, and it's the best thing that I've done.
When you first told me about you doing this, I was like, this is genius. Because, like, I mean, you're touching on it a little bit, but I think you could dive a little bit more in terms of, like, how much it does actually affect your efficiency, how much it actually affects the patient experience. Because maybe walk us through, like, you know, how many more patients are you able to see?
Yeah.
What is it like being that patient on the other side now that maybe some more time?
Yeah. So in the beginning, when you start to work with a scribe, it does take a little time before you kind of get up to full speed. But as I said, right away, you notice a difference. You're able to concentrate and focus more on your patient. When I'm using a scribe, I don't even have a pen. I can look my patients in the eye. I can listen. I can interact with them. And I know I have somebody that's recording everything that's transpiring, everything that I'm saying. And so it really kind of frees you up to really focus and listen to your patients and really understand where they're coming from and what the issue is so that you can make the best decisions for them. What I can tell you about using a scribe is that in tracking my before and after, my efficiency improved by about 30 to 40%.
Wow.
That means in a given time, in a given space, I can see 30 to 40% more patients. But I also feel at the end of that day that I could see patients for 12 hours straight. I just feel completely fresh at the end of a day because I'm not spending my time and energy navigating through a health record and trying to make it do the things I want to do and getting all the necessary charting and everything done. So with that work out of the way, I can just focus on what I'm good at and make the right decisions and just move on to the next patient, knowing that that patient's file is closed, the orders have been put in, the prescriptions are done, and I can move on to the next one and focus my energy on that.
That is, I'm sorry, it's so beautiful because I think, number one, you get to look at your patient in the eye.
Yeah.
And we are in the era of EMRs. Like we just got Epic put into our hospital system, which is, I think long-term fantastic, but because we're in the learning process, it's a lot of time staring at the screen, not on the patient.
There are a lot of studies out there looking at how electronic medical records have changed our interactions with patients. And if I'm not mistaken, the majority of healthcare providers spend more time charting than they do actually with their patients.
Absolutely.
Which to me is just insane.
And you think about why you get into this game. It's to have that human connection. It's to have that interaction. And I'll tell you, this might be too personal, but I was seeing, we were seeing a new family doc, whatnot, and they have the EMR tapping away at the computer or whatever, and they ask about your family history. And my dad recently passed away, and so I'm telling her, the circumstances behind that, and staring at the screen, it felt cold, even though I know she didn't mean for it to be cold.
Yeah.
But it was just a time where it would have been nice to have a little bit of a acknowledgement,
Acknowledgement. And you can pick up on that by not only the language, the verbal language, but by body language.
Absolutely.
And when somebody's turned away from you and they're staring at a screen, there's no way you have 100% of their attention.
No.
And my big problem with these, whatever EMR you're using, is the expectation is that you are able to somehow interact with a computer and a human being at the same time. Right. And it's just not possible.
No. And this is why I think this is so beautiful. The idea of the scribe is like, you take that away. You take that element of tapping away at the screen and hold a hand if you need to.
Yeah.
Look at somebody in the eye. I don't know. That's amazing. And the other part that really got me excited when I heard about this is the freshness. And,
yes.
For those that don't do clinical medicine, every little decision you make grinds at you. It grinds at you. Whether you want to call it decision fatigue or whatever you want to call it, it takes away your ability to make sound decisions in the opportune moments. You know what I'm saying? And if you're having to do all these little tweaks, touching up this console because, you misspelled, something here and there, like that's grinding.
Right.
And also the peace of mind that when you leave work, everything's done.
Yeah. That, you know what, you just hit on probably the thing that affected me most personally. I'm very interested in improving efficiency at work, in improving our patient care, in making sure that our patients have a good experience and a good relationship with their physician. That I can't see how you can't win with that. But from a personal level, I can tell you that there was a huge difference that I felt almost immediately, and that was with what you described as freshness. So, so you finish your day normally without a scribe, and you're gassed, you're tired. You've just given all of your energy to not only your patients, but to making sure the records are all straight, all this extra time documenting. Often I found without a scribe that I would have to spend at least an hour to sometimes more finishing charts, going back, adding details, ordering imaging, faxing prescriptions, doing all these things that, to try in an effort to try to stay on time with my patients but give them enough time. These are the things that you sacrifice and deal with later. Not having to do that, seeing your last patient, closing the chart, walking out the door, going home, and not having to bring your work home with you was a game changer.
Oh my goodness.
And just coming home feeling fresh, still having that energy, I could be with my family, be with my kids, and feel separate from work. And there's nothing that bothers me more than being at home and trying to be with my family when I know that there's work to be done still to finish my day.
Oh my goodness. I can guarantee you that Heather, your wife, could tell you the days that you have a scribe and the days that you don't have a scribe. So, we talk a lot about physician wellness and burnout, and this is another thing that could have such a large impact in terms of quality of life of clinicians.
Yeah.
And because going home and being able to properly engage with your family, not having something hanging in the back of your mind is huge. Like you and I, we both have 3 children.
Yep.
God bless them. And listen to your moms, okay, boys and girls. Having that peace of mind, improving family life, all good.
Right. And, people often ask me, the first question I get about using a scribe is, how much does it cost?
Yes.
And I imagine we'll talk about that. But if you had to put a price on that, I don't know what I'd be willing to pay to be able to know at the end of my day, I can leave work. I don't have to bring anything home and just kind of go full in with the family. That to me, I would pay close to almost anything to be able to do that regularly.
It's invaluable, man.
Yeah. So even if this wasn't a cost-effective endeavor in my practice, I probably would do it just for that reason alone.
Absolutely. And I could promise you, from what you described, we talked about this a little bit offline.
Yeah.
I would be shocked if it wasn't cost effective.
Well, I'm glad you brought that up.
Segue into pricing of said company.
So that is something that comes up very often. It's often the first question that I get from other physicians that are interested in the scribe is, sounds like a good idea, but how much is it going to cost me? Right? Yeah. Because we're all trying to make sure that we're running things efficiently, but that we're not paying for it too much ourselves in a way. But there have been a number of studies that have looked at scribe use in different settings, in family care, in emergency rooms, in urology practice, and every single one turns out that it's much more efficient. Mm-hmm. And there have been cost-saving studies. These were US-based studies, but they show that your return on investment is 6 to 1.
Really?
Yeah. And the average increase in efficiency is about 30 to 40%, but your revenues are increasing by something like 25%. Mm-hmm. And the average cost, so you're actually coming out ahead in terms of what you're able to bill and what it's going to cost. So my medical scribe is paid out of my own pocket, out of my own practice.
Yeah.
But when I really track that myself, my numbers really align with what's out there in terms of studies and literature.
Oh, good.
My efficiency went up. My cost of doing business went up a little bit, but more than the efficiency more than covered that cost.
Yeah, like you're netting.
I'm netting more.
Yeah.
I'm netting more.
That's beautiful. And the other consideration, of course, is going to be the patient experience, which we kind of touched on. But one thing, I mean, for sure, is patient comes in to see you at clinic and you're on time.
Yes.
I mean, they're going to have they're going to appreciate that.
Yeah.
But one thing, that we haven't touched on yet is how do they feel about having a quote unquote stranger in the room?
Yeah.
Maybe lurking. I don't know. I've never been in a room with the scribe. Maybe speak to that a bit.
So I think it's important, first of all, that when you're using a scribe or a scribe service, that you make it very clear what you want from that scribe. And from day one, it was important to me that I had a scribe that was essentially a fly on the wall. You really don't want your scribe to really be a presence in the room. They're sort of tucked back out of the way with the chart, whatever that may be, paper chart, or in my case, the EMR open and charting. Patients are often curious, but I have not had one piece of negative feedback from any of my patients. And often without the scribe in the room, I ask patients, so what do you think? Was that something that you were okay with? Is that fine? And most people say, I think it's wonderful. It allows you to focus more on me, and anything that allows for that to me is worth it. The other point I would make about patient satisfaction is that there have been a number of studies that look at scribe use and patient satisfaction. A lot of them show that patients will agree or strongly agree that their patient-physician interaction is actually improved with medical scribes, most likely with that sort of feeling that focuses on them. It's also interesting to note that people often perceive their time with the physician to be more than it actually is with the scribe.
Wow.
So you could be spending the same amount of time with a patient. They're perceiving it as being longer. And that likely comes back to that being able to focus and listen and address them. They feel that, and they perceive it as you giving them more attention over a longer period of time.
Wow. I mean, those are great points. So basically the literature is not saying that it's a bit awkward having that person in the room. It's more positive interaction with that clinician, with that physician.
Yep.
Oh, that's amazing.
And there's another point that I wanted to bring up specific to my practice. So as I mentioned, I see mostly female patients. I'm dealing mostly with pelvic floor disorders. And so a very important part of my practice is physical examination, including internal exams and pelvic exams. As a male physician, I would imagine even as a female physician, you may be putting yourself in a difficult position, or you're setting yourself up for a problem if you're doing that on your own. So I have never done a physical exam without a chaperone, and I never will, because I know of instances where people get into trouble.
Right.
And that's something that's very important to me, and something my mentor taught me. And generally speaking, in my field, that's how things go. I was running into a lot of problems with finding someone available to chaperone. So when I needed to do a physical exam, it would require me to go down the hall, find a nurse, bring a nurse back, or get whoever is around, which is less than ideal.
Not efficient at
So when
all.
I have a scribe with me, they can also sort of act as a chaperone. They're there with me. Their name is in the chart. So it's another piece of efficiency for me, but also protective in some way, because I have another person with me that can chaperone the exam and kind of verify that what happened.
Actually happened. So it's like 2 in 1. Like you're getting the scribing value, and you're also getting that chaperone.
Yeah.
That's brilliant. It all comes down to that hashtag freshness. I really think that's the beautiful thing about this. I'm going to switch gears a bit to the other part that I think you're creating some innovation and wonderfulness. Do you call them virtual clinics, or what do you call them? Distant clinics?
I think that's a good way to describe it. The official term is e-consultation.
Okay.
It used to be known as a personal computer video conferencing, or PCVC. The terminology now is e-consultation. So to just be totally clear, it's not an innovation that I came up with,
right,
but it's something that I've embraced into my practice. Mm-hmm. And here in Ontario, that has been quite easy because there have been some advances in Ontario telehealth and the Ontario Telehealth Network. So if you wanted to set up video conferencing, for example, in the past, what you needed to do was walk down to a room dedicated to video conferencing, connect with your patient who was also in a room in a hospital or a clinic dedicated to video conferencing. And that was very often to coordinate. So my experiences with that setup was that often you are somewhere else. You can't get to your appointment at that time. There's not really a waiting room. So often you would miss that connection. And sometimes patients wouldn't be able to make it to the hospital to see you. Mm-hmm. For me, that was in the neurogenic population that I work with, that tended to be a big issue because it's hard for them to get to the hospital. It's hard for them to access those rooms. And so we were having a hard time making that connection. That population in particular was the reason I really wanted to have this as an option, because for them to come and see me for what might be a short visit, these are patients that I'm seeing at least once a year. These are patients that need to be surveilled for their lifetime because of the nature of their lower urinary tract dysfunction, because of their high risk of complications.
Right.
They need to be followed. And so when I started to work with these patients, I quickly understood that these visits, these 5-10 minute visits for me to say, how are things? Oh, they're good. Your ultrasound looks good. Okay, I'll see you in a year. To me, that's 5 minutes of my day, 10 minutes of my day. For these folks, it's a whole day. Yeah. They need to go through their routines in the morning, which are often lengthy. They have to arrange for transportation, which is often within, a pickup is within a 2-hour window. Then they would come to see me. We would have our visit, and then they would be waiting for the same transport home, which is often, again, within a sort of large window. So this is a whole day for them to come in to see me, to tell them that everything is okay. Wow. So trying to look for a solution to that problem, we started doing phone calls, but phone calls, as you know, aren't really above board in medical legally. There isn't really a way to document that. And, there's not really a way that you get reimbursed for that in our fee-for-service model. Yeah. So it's a deterrent for a lot of people to offer that service to their patients. And truthfully, you don't want to spend your whole day talking to patients on the phone. There is something that you miss in terms of body language, in terms of connection, when you're just talking to somebody on the phone rather than interfacing with them. Maybe video conferencing isn't as good as being in the presence of someone, but I think it's a much better substitute than talking on the phone. So Ontario Telehealth developed this PCVC, or personal computing video conferencing, which now is referred to e-consultation, where you can connect with your patients if they have a smartphone, if they have a tablet, if they have a computer that has a built-in microphone and a camera, which almost all devices do now anyways.
Absolutely.
It's a matter of getting their email, scheduling an appointment, and sitting down at your computer wherever you are. So whether that's at home or your office, when you're driving, not when you're driving. Starbucks, yeah. No, somewhere private and preferably not in your vehicle, that you can connect with your patients. So I've started doing that in the last, say, 6 months, and it's been just a resounding success. My patients are extremely happy with it. They like the interaction. They like to be able to see me. I like to see them.
Right.
And it makes a big difference.
This is, you say a big difference, is a huge difference.
Yeah.
That day for them, especially when you think about, we did the extreme end with the patients that have neurologic disorders, but even you got Grandma Gertrude or Grandma Nelson that needs to come over to the clinic. Her daughter has to take time off work to be able to bring her over to the clinic. If they live out in Arnprior, I'm not sure where that is, but Arnprior, it takes 45 minutes to get in. You got to find parking, right? For literally a 5-minute visit.
Right.
You know, like it's not for everybody. Like if there's something that's more complex or whatnot, yeah, fine. In-person consultation makes more sense. But something that collectively you feel like does not need to be seen in person, like it is brilliant, really.
It works very well. And you're exactly right. It's not just for that select population. I've really started offering it to anyone. And I think everyone appreciates it.
Oh, I think you get it on both sides. The clinician appreciates it. The patients and their families appreciate it. I even think within ICU, this is something that we could be doing more of, because we often will get the outside calls, like the patients from wherever that might be, a smaller peripheral hospital, and they're asking for your guidance. You know, and often you get the story, it's pretty clear that they need to come, but sometimes it's not. And you get the story, you're not sure what to do. It'd be so nice to be able to see the patient to really get a sense of how sick they are, because sometimes you get it on both extremes. Actually, you bring them when they're not that sick, and they're literally like eating bacon and egg sandwich or bacon and sausage sandwich as they're walking in the door.
Beyond meat.
Beyond the meat. They walk in, they literally could walk in through the door and you're like, oh man, we just engaged an ambulance or Orange, like expensive transport medical service. You got to do new admission work, like all these like resources that were mobilized for really no reason. Yeah. And then sometimes on the other end of the spectrum, you see somebody, they give a story where they don't sound that sick. And then they come in and they're like ultra sick. And you were like, oh, I wish we could have seen that patient, brought that patient in earlier. So I think that technology and that the technology, bringing that into more than, just clinics has a lot of potential upside.
Anything that will prevent patients from complaining about parking is worth it. It's the number one complaint at the hospital, parking.
What about food?
That's way down compared to parking.
I saw somebody straight up, they were eating pureed French toast. And I stopped what I was doing. I think I was just walking by the room. I was like, what's going down right now? And they're like, oh, this is my pureed French toast. And I just, just started dry heaving. It was a bit awkward. They're like, Dr. K, you okay? I'm like, no, look at this.
When they bring those food carts down the hallway, I need to step in the hallway with a can of Febreze and just hose it all down. I'm like, I don't know what's in that cart, but I don't know how humans eat that.
Yeah, absolutely. Like, I saw something that looked like legit like a rugby ball. Hashtag rugby ball deliciousness. Okay, so Duane, I think we're getting to the end of our fantastical conversation. And I think a new part of the Solving Healthcare or Quadcast that I want to bring to the table is ending on a positive note. So I was sitting on an interview yesterday for future intensivists. They were doing their fellowship interviews. And this kid described this story about one of his first patients. She had a diagnosis of cancer, terminal cancer. And he was describing how engaged he was with the family, like meeting with them every day, spending some time talking about her worries and her fear of dying and having a really genuine interaction with the family. But he even said, call me when she dies to the son. She goes, call me and I want to be there with you. Yeah. And when he was describing the story and she dies and he comes, sees that family, they hug it out as he was describing. I'm like, this is what we got into this game for, that connection. And, in a previous episode, we talked about villainization of docs and clinicians. And really, when you hear stories like that, it makes you realize we're here for good reasons. Like, we really want to provide great care. And when you hear, I won't lie to you, I was getting verklempt in the interview. I was sitting next to Gianni. I'm like, you're not going to see my ass cry. You're not seeing that tonight, boy. I'll never hear the end of it.
I'm feeling a little verklempt.
A little verklempt. But I wanted to hear from you. Did you have any story similar to that where you got where you connected with a family or a patient and it left a mark with you?
I could think of a few, and they all come with these very old, sweet ladies that have these terrible pelvic floor disorders, and they come to see me regularly for therapy. And every time I see them, they insist on a hug, and it's like the best part of my day. Just getting a nice hug from this, bending over, giving them the nice hug. I love it. It just brightens up my day. And I know we're not supposed to hug our patients, or so we're told. But
Is that true?
Well, I think
I hug my patients.
I love it.
Yeah.
And when it's real, it's great.
Yeah.
I'm not good with the fake hugs.
Yes. And none of you could see Duane Hickling, but he's not a small man. And I was just making sure you don't crush poor grandma.
Yeah. I have to hold back.
Finola.
I have to hold back sometimes.
Yeah, you can hold back.
I do. I did have a really awesome experience yesterday that I wanted to share.
Okay.
When you brought this up, I was thinking about it right now. So I'm finishing my day, and I see this patient who I treated for kidney stones, and I saw him, and I knew he didn't have an appointment, but he came over and kind of stopped me in the middle of my day, and he said, "Hey, I just wanted to come and say thank you for everything that you did. I'm feeling a lot better. I'm very happy." And he said, I made you something very special. And so he said, "Do you want it?" And I said, "Yeah, sure, I guess so." And he said, "Okay, just a minute." And he reaches into his coat and he pulls out his wallet, and he opens up his wallet, and he pulls out this little baggie, and he's like, "Here." And he gives it to me. And he's like, "I want you to have this." And it was his kidney stone. And he said, I don't want you to send this to the lab. I don't want you to do anything. I want you to take this and put it on the mantle at your home, or put it up in your office. He's like, "I made this for you." I thought it was so funny.
Oh, that's amazing.
Yeah. And I'm like, it actually is kind of like a pearl, I guess. So I made my wife a necklace out of it. Don't tell her it's for Christmas.
It's for, I guess her birthday just passed, so that would make more sense. Duane, thank you so much for coming. This has been so much fun, and you're definitely going to have to come on again, because I don't know, I've been looking forward to this all week, and I think it lived up to the hype.
Me too. I was so excited I couldn't sleep last night. I had a great time. I think this is a great show. You're the perfect host, and I look forward to doing it again.
Awesome. All right. Thanks so much.
Once again, everybody, thanks so much for listening. I hope you enjoyed episode 4 with Dr. Duane Hickling. In terms of take-home points at an administrative level, consider investing in technologies such as virtual clinics or even medical scribes to enhance that patient experience. From a physician-clinician point of view, investing in scribes will allow you to have that enhanced patient interaction, and also consider the idea of virtual clinics to allow patients and their families to not have to go so far out of their way to have that, to have to see you. And lastly, from a general public or patient point of view, engage your docs, engage your specialists. Say, why do I need to come see you? Why can't I have that interaction via smartphone? Maybe that medical scribe interaction will help us to have a more authentic interaction. So consider these things. Last couple notes. If you want to send any comments or feedback, please send them at quadcast9er9er@gmail.com. That's quadcast99@gmail.com. You can follow us at Twitter at Quadcast. Last thing, we're going to attempt our release dates to be on every Tuesday or every second Tuesday. We do have quite a few guests lined up for the next little while, so we're aiming for every week. So I hope that works out for you. Thanks again for engaging and listening in, and we'll talk to you soon.